Good afternoon, everyone. We are Group 22, and we will be talking about our program, Soldiers to Civilians. Though the U.S. government has taken great initiative to help veterans suffering from PTSD, there is still a need for programs that both address the social stigmas associated with PTSD and ensure that veterans follow through with their treatment plan. Our project goals are to promote better outreach to veterans in the city of San Diego, reduce the stigma associated with PTSD, and veterans in San Diego, California, and improve the access of care for veterans in San Diego County.
Our evaluation questions are as follows. Would normative belief based on family support level affect the veteran success rate of following through with seeking treatment for PTSD? Our second question is, would attitudes based on comfort level affect the veteran success rate of following through with seeking treatment for PTSD? And our last question is, would the veteran's intention to seek treatment affect the veteran's success rate of following through with seeking treatment for PTSD?
Theory of planned behavior has proven to effectively predict and change behaviors related to interventions focused on the target population's beliefs. Theory of planned behavior has been used in various studies with veterans as its target population in relation to mental health. Within the scope of our intervention, our program's aim is to change the normative beliefs surrounding veterans with PTSD and to ensure that veterans not only have appropriate access to care, but also increased self efficacy, enabling them to follow through with their treatment plans.
For our research design, we chose a non-experimental design. We conducted a pre-test and post-test survey to determine our intervention's effect on the attitudes, norms, behavioral control, and intention of participants' decision to seek or not seek treatment for PTSD. We originally started with 110 participants, but due to dropout, our final sample size was 100. Some advantages of this research design are that it only requires a small budget and is convenient to conduct if the program is limited on funding and time. Some disadvantages are that it cannot prove cause and effect relationships. It relies on observation and it cannot control for external factors. Our sampling procedure was based on a convenience sample. We passed out flyers and held informational presentations at the SDSU Veteran Center and veteran support groups in order to recruit participants for our program. The veterans with PTSD that wanted to join the program were given surveys and were allowed to participate. The independent variables we assessed are attitudes, behavioral control, norms, and intention. The dependent variable we assessed was the outcome of receiving treatments. These variables were analyzed via survey questions. For example, survey question 1 was about attitude. So on a scale of 1 to 5, how comfortable are you with seeking treatment for PTSD? As you see on our graph, these participants were not that comfortable. Survey question 2 is about perceived behavioral control. On a scale of 1 to 5, how confident are you that you can seek treatment for PTSD? As you see on this graph, these participants did not feel that confidence. Survey question 3 is about norms. On a scale of 1 to 5, how supportive do you think your family is about you seeking treatment for PTSD? As you can see on this graph, most participants felt supported, but not entirely. Based on our evaluation question regarding intention, our team found that before the intervention, 62% of participants had the intention to seek treatment. After the intervention, 87% of participants actually received treatment. Based on our evaluation regarding norms, our team found that even among participants that scored a 1 or 2 on the survey, meaning they did not have much family support in seeking treatment, we had high follow-through of treatment rates. Out of the participants that responded with a 2, 88% of them actually did receive treatment following the intervention. Based on our last question regarding attitudes, our team found that most participants received treatment for PTSD even if their level of comfort with seeking treatment for PTSD was low. Both 1s and 2s had success rates of 90% and 81% respectively. As you can see on our tri-square, these are the results for our analysis. For our null hypothesis among all interviewed veterans with PTSD, there is no association between participants with the intention of seeking treatment and participants that actually received treatment. For the alternative hypothesis, among all interviewed veterans with PTSD, there is an association between participants with the intention of seeking treatment and participants that actually receive treatment. In comparison to alpha value of 0.05, our p-value is less than the 0.05 threshold, making it statistically significant. This means that we can reject the null hypothesis. Thus, we can conclude that there is an association between the participant's intention to seek treatment and actually receiving treatment for PTSD. The correlation between the number of participants who receive treatment and their attitudes towards seeking treatment for PTSD is positively correlated. Those who felt more comfortable towards seeking treatment did have higher success rates. We see from this graph that the two variables we assess, number of participants who receive treatment and norms towards seeking treatment for PTSD, are positively correlated. The more supportive their families are, the higher the success rate of those veterans following through with seeking treatment for PTSD. Overall, our program met most of its goals and objectives. Our findings revealed that through our program, we were able to convince participants to receive treatment for PTSD. Even though our data revealed that our intervention leads to a high success rate for attitudes, norms, and intention for veterans seeking treatment for PTSD, we cannot conclude that our intervention is the sole cause of these success rates because this was a cross-sectional study which cannot determine cause and effect. The limitations of our study are social desirability, which could lead to response bias from participants, lost contact or dropouts, small sample size, which leads to unstable data, no control group, so we can't control the confounding variables, no randomization, so there might be biases, limited funding, and cross-sectional study only yield the prevalence data and cannot determine the cause and effect.
Here's a timeline of our program that took the course over the year. We had many classes throughout the year for our veterans, but the most important dates were at the end of May for our pre-test, January for our post-test, March for a data analysis, and now we're grateful to be able to present to you guys our findings and results.
And that concludes our presentation. Thanks for listening.